good evening, good afternoon, depending where you are in Canada. Thank you for joining us for our PACE Clinical Care Pathways, which will be presented by Dr. Karen Kroeker, and I will be moderating, but I am Marie-Louise Martin and not Jennifer Stratton. So today's webinar is hosted by CanIBD. And what is CanIBD? It is a consortium of nurses across Canada working in the field of inflammatory bowel disease and is supported by Crohn's Colitis Canada. Our vision is to ensure people of all ages living with IBD in Canada receive high quality clinical nursing care within a multidisciplinary team. CanIBD is committed to improving the quality of care for people living with inflammatory bowel disease by providing mentorship and learning opportunity to IBD nurses in Canada. It also creates opportunities for networking and sharing of best practice. It also aims to develop and adopt nursing guidelines and standards for IBD nursing within Canada and elevate the profile of IBD nursing in Canada. If you have not already done so, please check out the CanIBD website for various preceptor and learning opportunities that are available. It is my pleasure to introduce our speaker today, who is Dr. Karen Kroeker, and is an associate professor of medicine at the University of Alberta. She completed her Bachelor of Science and MD from the University of Calgary, and then went on to do her internal medicine at the University of British Columbia. She then moved to Edmonton and completed her gastroenterology at the U of A and an advanced clinical and research fellowship in inflammatory bowel disease. She also received her Master's of Experimental Medicine at the U of A in 2012. In 2010, she joined the Faculty of Medicine, where she's been a leading member of the IBD clinic there, and she also specializes within the pediatric moving to young adult care. And the one thing that is missing from her bio is her fantastic taste in shoes, and if you ever see her at a meeting, make sure to check out her feet. So I'd like to thank our sponsor for today, and while the list looks small, we do have a number of people who will be coming on board, but officially right now our sponsor is Oregon. So thank you to them for sponsoring our talk tonight. Dr. Kroeker?
Thanks, Marie-Louise. I do like nice shoes, but as I get older, I want to wear flats more and more, I think. So it's, but I still like fun shoes. Okay, so let's get started. So thanks so much to CanIBD and the group for inviting me to present today. This has been a project that we've been embarking on for a number of years, and we're excited to share with the developments that we've been doing over the last little while. So my disclosures, I have a few disclosures with drug companies like most people do. I try not to be too involved with the drug companies, but I'm a little bit involved. So today we wanted to talk about the clinical care pathways for IBD. These are tools for healthcare providers in aiding the management of patients with IBD. And to talk about the standardized and evidence-based CCPs developed by the IBD clinic here and in Calgary, and then how we've moved forward with the Crohn's and Colitis Canada. And then explore the application of CCPs in the management of patients with IBD. So what is a clinical care pathway? So clinical care pathway is generally defined as a structured care plan that describes the timing and actions required by providers in order for the patient to meet targeted goals in a timely fashion and reduce the incidence of preventable errors. And these have been actually shown to, when implemented, to improve patient outcomes, reduce hospital length of stay, and decrease healthcare cost. And they're actually a really important method of closing the gap between the evidence and actual practice. So we currently have 17 clinical care pathways that are divided into 7 domains: flare management, advanced therapy management, steroids and immune modulators, information on Crohn's, information on ulcerative colitis, and then we have some health surveillance and maintenance, and then special populations. So where to find the CCPs? So currently they're on our website called ibdclinic.ca. So someone was like, how did you get that domain? I've like no idea how we got that domain, but we're happy to have it because it is quite easy. So this is what our pathway looks like. And so it is specific, some of it to our clinic in U of A, but there's a lot of information on there with our clinical care pathways and the resources that you might want to access. So we're going to go through this a little bit more. I just zoomed in a little bit. So our pathways are found on this link with clinical care pathways. And then resources, for example, patient information sheets, are found in that resource section. So I will say a caveat, we are in the process of updating our patient info sheets. I know Barb Curry, I think, sent us a bunch of resources that we're going to hopefully be able to utilize to like update our website. So what is the background of CCPs? So I don't know if any of you know, but in Dr. Fedoruk, but in 2014, this was his vision. So if you think about that, was 10 years ago. And he really wanted to improve clinical practice and the care of IBD patients in the process of standardization. And so this was a process where we consulted an expert opinion with stakeholders, and this was a collaboration of Calgary and Edmonton. And so we involved physicians, IBD fellows, nurses, admin support, dietitian, pharmacy, as well as our nursing managers. So this was a real collaborative process. And then in 2016, there was the PACE initiative as Crohn's and colitis put out. And our task in Alberta was to move forward to integrate this into the EMR, which was actually more challenging than anticipated and still is a long-term goal of us, but we're moving towards a provincial EMR and hopefully begin to be able to incorporate more of them directly into our EMR. So this, I'm going to tell you a little bit about our project that we did. So we did have a graduate student here, Reed Sutton, who actually worked really hard with Epic. I don't know how many of you have Epic as EMR. And we integrated a flare pathway into the EMR. And so what happened was it was done as a best practice advisory. So if you put in IBD, and then it would actually pull up this best practice advisory. And to activate it, you had to fill out their HBR or partial Mayo. And so we actually found as a result of this pilot project that we improve the documentation of clinical scores, so the HBI and partial Mayo as objective markers, and then also an increase in measurement of flare labs, including measurement of FCP, as well as stools, drool, and infection. The interesting thing, though, is there's still only a moderate adoption of the best practice advisory. About 25% of flare encounters actually used it. But I will tell you that there was better adoption by the nurses using it, 30.5% of flare encounters versus only 6.7% of our physician encounters. So that's kudos to nurses. And so actually, it's a little bit why I'm excited to come present to you guys today, because you guys would be integral in updating or activating these pathways. So one of the challenges with pathways is, as you guys all probably know, is that over the last, since 2001, so almost 25 years, there's been a huge change in therapies. So this is kind of like the approvals in Canada for Crohn's in green and the approvals in Canada for ulcerative colitis. And as you can see, the medications have just really increased over time. And so back when we started in 2014, we really didn't have a lot of medications yet. And so this is a part of what the challenge has been, is how do we keep these clinical care paths updated so that we can actually make sure the information is usable, because we don't want to be practicing 2014 medicine in 2024. So in 2019, we actually met. Interestingly, this was like in December, so not long before the pandemic hit, which probably kiboshed all of our plans to do things. But we actually did a workshop with Alberta providers, and we actually came up with this kind of standardized process in order to standardize renewal. So some of our CCPs we thought are actually not likely to change quickly, whereas other other like pathways were actually high risk to change. And then some have a relatively low clinical impact. And so that might be something like vitamin D replacement or iron replacement, that they're not that high on impact. Whereas management of patients with like biologics or biosimilars, that sort of thing, any kind of advanced therapy, we thought that this would be high risk to change. And so we wanted to make sure that these are reviewed on a more regular basis. So we came up with this kind of grid where we would actually classify each EPA as things, or each pathway as something that how often we review it. So we would identify the gaps in the needs. This is how our pathways are made, review the literature, organize critical review, vote on experts, and then launch on our websites. And so this is the whole thing where we review all the CCPs every 1 to 3 years, depending on this grid. So I'll show you a list of our clinical care pathways from this workshop. And as you can see, there are some of our pathways that were deemed level 2 or low risk, but high clinical impact, whereas some things like biologic therapies were higher risk, whereas vitamin D replacement, health maintenance, those were low risk. And low clinical impact. So probably don't have to be assessed as often, although we still want to make sure we're not leaving them out there for too long. And so then the next phase that we wanted to do was actually, how do we nationalize these? And so this was kind of an Alberta initiative. And so the PACE program, as you probably know, with Crohn's and Colitis Canada, is really about a lot of nationalizing projects. And so basically we've been working on this. So it was Dr. Fedoruk and myself at the U of A, and then Reno Panettiere and Cynthia Seau at the University of Calgary. And so basically the reason was the lack of standardized care. And we basically want all Canadians living with IBD to receive standardized care. And we thought that these clinical care pathways, informed by best available evidence and expert opinion, could help us be used to standardize care. So the impact was that we wanted this to be widely applicable across provinces and regions. And then we wanted to ensure adaptation of clinical best practices through actionable protocols. And the strategies were developed that CCPs are regularly reviewed and updated to incorporate the rapidly evolving evidence. And so we believe that this will improve patient outcomes in terms of managing, reducing unnecessary acute care visits and admissions to hospital. So this nationalization process is the maintenance and uptake, ensuring evidence are current. And this has actually been done by a working group of really committed multidisciplinary stakeholders, which regularly review, revise, and update. And this includes gastroenterologists, academic and community, IBD nurses, colorectal surgeon, and patient partners. And so we have kind of a different core group of stakeholders that are committed. There's an advisory group that's kind of high level, that's actually responsible for proving the need for new CCPs. So anyone within our group can actually apply and say, I think I have a new idea. So one of the current pathways that we're working on is this transition to, from pediatric to adult care. So that one's not quite been updated or approved, but it's in development currently. And that's one of the things. And so the advisory group reviewed it and said, yes, I think we do have a need for this, and we're going to work on developing that. And then we've created a process where each pathway has both primary and secondary reviewers, and they're responsible for the kind of day-to-day pathway management to make sure they're maintained. And then they present the updates to review to the advisory group. And then all of our group conforms this working group, which are responsible for assisting development and reviewing and voting on the changes. And so we've been meeting every year, the last 2 years, after mentoring an IBD in Toronto, to make sure that we can keep these updated. So some of our nurses here on the call today, I know, are been involved in this process. We're really grateful for the work that they do. So the format of our CCPs are kind of all developed the same. So basically there's objective, there's like which patient population does this apply to? There's a highlight box, and there's a little bit of introduction, and then there's step for providers. So that would be either physicians or IBD nurses, kind of clinical providers, and then there's steps also for support staff. So I'm going to give you an example of this is what our website looks like. So if you go to the initiation, there's like all the clinical care pathways. And so say we're going to look at initiation tapering of corticosteroids. The objective is to minimize the risk of repeated steroid use. This is adult patients with a known diagnosis. And then the highlight box is something just important. Steroids should only be used for short-term induction therapy to treat acute flares. And then there's some information on how we define it. I didn't have the whole page here. And then on every clinical care pathway, we do have a PDF download that you can pull down. It has all the same information, which actually gives you a bit more information about all the different steps that you need to do for this. So this is just one of the examples. And so we're really excited about this. And so I'm going to show you a couple more things about this. So this is a little bit more of the paper. And so the objective, the patient population, the highlight box. And then if we zoom in a little bit more, you can see that there's something, this is with the steroid induction. This is linked to this PACE quality improvement thing, quality indicator. And so this is like calcium and vitamin D are recommended in conjunction with systemic corticosteroids. And so this is what these are based in. So I don't know if you guys are familiar with this PACE quality indicator paper, but this is where it's found. It's at IBD in 2019. And so we wanted, wherever possible, to ground these CCPs in these quality indicators. So let me keep going. And so I'm going to say just a little bit of how we're going to adapt this to a case. So this is a flare case. So this is an ulcerative colitis flare. So I think I did really young cases for all of them, but this is a 24-year-old female with known ulcerative colitis, and she's just on 5-ASA. And she calls the office with the symptoms of a flare. And so the call gets directed to the IBD nurse, and a new IBD nurse in the clinic takes the call. So what she would do is she would go to the website, or ibdclinic.ca, and this is where she'd find it, and she'd click on the flare management pathway. And so for a suspected flare, this would be optimal management of IBD flare. And this is the patient's. Yes, this patient fits adult patient with a known diagnosis of IBD. And then this is basically used to triage patient symptoms and determine your degree of urgency, and use clinical judgment, assessment, and knowledge of IBD in consultation with a physician or nurse practitioner to determine further treatment. So this is they would gather information by this phone consultation sheet, as well as calculating their HBI and their partial Mayo. So this is kind of our IBD intake sheet. And so this is, and you can adapt this to your clinic as how you need, but it's like the patient name, all these things, and it's like how many symptoms people are having, what's their usual, what's their current, how much blood, what's the consistency. And so an experienced IBD nurse probably knows to ask most of these things, but by having this to follow, it actually helps be consistent in making sure you're asking all the right questions. Like, are they up at night? Do they have fecal urgency? Is there other symptoms? How is it impacting their day-to-day life? Their change in daily activity? Are they going to school? Are they going to work? And then there's some other things. Are they having weight loss? Are they pregnant? Is there any other changes that we need to know? And so what this does then, and this is the bottom part, is that depending on the symptom that people have, people can actually have testing or things that you would, or steps that you would do. So for this person with an increase in diarrhea, we would send them out for flare labs, as well as do stools for C. diff and CNS. And then the O&P only if the patient was traveling or camping. And then we'd make sure the rec was sent, and then the patients would be instructed on how to do this. Other symptoms, sometimes you might be doing other investigations. So this really helps guide the care. So in this case, she was having 6 bowel movements per day, increased from 2 to 3, about half of them with blood, but she denied any significant abdominal pain or bloating. But then she does say she got antibiotics after a dental procedure about 2 months ago. So under the direction, they actually did all these investigations. And then in our pathway, we have it that patient will call back once the specimens have been submitted. Because if they take a few days, you can't just keep looking for those, although the results will come into our EMR. So our lab is pretty good, and they actually usually call us when the C. difficile results are positive. So the actual lab actually called us to say the C. diff was positive, toxin positive. And so then the physician sent the prescription to the patient for the vancomycin, and the nurse would call and make sure they're aware of the results. And then the patient is instructed to call back if they do not improve with the treatment. So we always want to have some sort of like expectations. It's a little bit of what we, with patients, to say what to expect. And so in this case, the patient improved and actually followed up with the team with the next regular scheduled visit. But if they hadn't, then they might have to go down a different of the pathways. So I'll do one more. I think I don't know if you guys, many of you know, but my first love for IBD is peds transition. So a lot of patients that I follow are actually diagnosed in peds, which means I have a relatively young population. And so this is another case. This is a 23-year-old female with known ileoclonic Crohn's disease, diagnosed in peds. And so this was at age 16. And as many of you know, if you're familiar with peds IBD, they use exclusive enteral nutrition as actually induction, and then maintenance was actually Imuran, and she has been compliant with her therapy. So she was seen in clinic, and over the last 6 months, she has increasing symptoms. So her HBI is 7, and so she describes her overall well-being as slightly low par. She's having moderate abdominal pain. She's having 3 to 4 loose bowel movements. She's having joint pain, no other EIMs. Her fecal cal is elevated, was only 100 last year. And then the plan in the clinic was seen by the nurse practitioner was endoscopic assessment and to prepare for advanced therapy. So if the nurse was directed that, can you please help prepare this patient for advanced therapy, they would actually go to our induction of advanced therapy pathway. And so this is objective to ensure a safe start of advanced therapy. This is an adult patient, and this is the pre-therapy considered for all patients. So this is all the steps that we want to do, is take the history for things that would maybe make a contraindication to certain types of therapies. They would do pre-testing, make sure there's a chest x-ray, a TB skin test, or quantiferon. If you're considering an S1P modulator, you're going to do the EKG. And then you want to review if your vaccinations are up to date, and then make sure the fecal calprotectin, although they had one, so it was already done. And then the thing is, we need to review insurance options and provide appropriate startup sheets and information sheets to the patient. And then depending on which therapy gets started, even though you're just preparing, we haven't made a decision yet, that you would plan to reassess them in a couple of months to make sure they're actually getting better. And so the support staff would arrange the appointment, and then we'd also use the health maintenance protocol for monitoring of adverse events and prevention of other diseases. So this, once again, if you can see, is grounded in the CCC, the Crohn's and Colitis Canada PACE quality indicators. So before starting an anti-TNF, you have to do latent TB and HB screening. And if they're HBs surface antigen positive, you would put them on antiviral treatment when you're starting an anti-TNF. So this is what you do as the pre-testing, but we also have a therapy decision tree to help in figuring out what's the best treatments to treat either Crohn's disease or ulcerative colitis. So I'm going to show you, this is the beginning of it. The objective, provide direction. It's adult patients, and these are depending on the different anatomic locations, severity of disease, complications, EIMs. And so and just a comment that new therapies are constantly being developed as we know. So this is a little bit hard to see, but this is kind of like these are the assessments that we would do. So the goal of therapy is deep and prolonged remission with long-term goal of preventing complications and halting progression. And deep remission is a combination of symptomatic and objective markers of remission. So the things you want to assess the status of the inflammatory disease, and this would require symptoms, testing, as well as imaging, including endoscopy or radiology, and or intestinal ultrasound. And then assess comorbidities. So some things you want to rule out infection, you want to see if there's stricture problems, and you want to review their medication history. You want to look for perianal disease. You want to consider other inflammatory mediated conditions like angst-bond or arthritis or psoriasis or pyoderma, because you might want to choose, this might direct your change in therapy. And then you want to kind of figure out predicted severity of disease course. Are they high risk? And so these are factors that we think are moderate to high risk. Active smoking, if they're in hospital a lot, if they have perianal disease or stricturating penetrating disease, if they've had a prior resection, if a lot of their bowels resected, or they were diagnosed young. So if none of these are, then we think it's low risk. So there is a low risk algorithm, but I've just skipped over it because this person would be moderate to severe. And so then basically the treatment options would be induction. You would consider steroids with a taper. She's already on the thiopurine, so this is not going to be enough. And so this is why we're looking at the advanced therapy. And so once you choose an advanced therapy, then we would either, we would assess for symptomatic and biochemical response. If not, then we'd have to go to our loss of response protocol. And if they are, they would continue their advanced therapy. And then we would assess for endoscopic healing in 6 to 12 months. And then the other important thing of this, if there's symptoms, we always have this thing where, when you send people home, you want to make sure they know when to call us. And so we always want it because we can't check up on everybody every week. And so that's kind of one of it's like kind of interlinking protocols for management of patients with Crohn's disease. We also have a number of, remember I told you we have some health maintenance pathways. And so this is actually our health maintenance pathway. And so it's one of the things that I think sometimes it's really important as the IBD nurse to really help with health maintenance, even though this is done in conjunction with both the physician providers as well as the family physicians. And so this is what it is prevent the development of other diseases and monitor for adverse effects of therapy. So these are patients with IBD. And then we know that they're increased risk of infections, metabolic bone disease, certain cancers, mental health, as well as infections that can be prevented. So this is basically what this is the recommendation: annual review by the family physician, and the annual review by an IBD specialist. even if the patient is not on therapy, and depending on the therapy or your trajectory, it might change a little bit. And then we always have to consider, especially when people have chronic disease for greater than 8 years, that we have the colon cancer dysplasia screening. And so this actually would link to our colon cancer dysplasia pathway as well. And then, as you know, especially for people with Crohn's disease, you want to always be counseling for smoking cessation. And there's education stuff, and we also have a smoking action plan. And then we always want to think about diet and nutrition. So educational materials about diet. I know there was just a brand new paper sent out, I think published recently, because our dietitian was showing this to me just earlier today about the new diet stuff that's being recommended. So we're going to have to update and add that to our website. And so if they have ileal disease, you want to consider if they have B12 deficiency, you want to make sure their iron's okay. And then we always want to make sure their vitamin D is okay. And then as needed, we refer to the IBD dietitian. And then vaccinations is really important as well to ensure the vaccinations are up to date. So we have a vaccination guide, and then also counseling for the annual flu vaccine, the inactivated one. And then we think about annual screening. So skin examination for melanoma. So we often delegate this to our family doctors, or if they have high risk lesions, then often this would be done by a dermatologist. We have to think about oral health. Are they going for the regular dental care? Are they getting their eyes checked as needed, especially people that have been on steroids? And then pap smears for immune compromised women, the cervical cancer risk, and routine breast exams. So some of these things are actually, we often delegate to our family providers, but it is important to provide guidance to them in communications to make sure they know what we're looking for. And then for behavioral health, we want to address and assess for screen for mental health comorbidities. And then if patients are high risk for anxiety or depression, we would either refer to primary care or other mental health professionals to help with that. So I think this is a really good resource on helping us make sure we're systematic in our health maintenance plans. The last thing that we want to show you that's on our website is that we do have patient information sheets, and this is some of the ones that we're going to be updating with the help of Barb. And so this is like the example of the azathioprine sheet. And so this is what we often give to patients. So it doesn't have like the thousands of side effects, but we also talk about the ones that are most important. And so basically, so people have a little bit of a simpler form. So this is a little bit longer than this, but I think I only put in the first thing. The other thing, if you look at our website in terms of the resources, we have these startup sheets. So these are technically Alberta specific, but a lot of them are pretty similar depending on where you practice. It's just that you wouldn't have Alberta non-group coverage. I think in BC you have Fair Pharmacare, and I think in Ontario you have Trillium. And so there are the forms that you would need. And so this is the little bit of like for Inflectra, how we enroll you in the patient support program. If they have private coverage, you can give the DIN number so they know. And then there's wellness things where the pre-testing, a little bit of stuff that we give to patients so that they know what we're all looking for. So they need to have their chest x-ray, their skin test, and the hepatitis serology, and the family doctor, the breast exam, the pap smear, and that sort of thing. So this is a one-stop information sheet. So I think the one thing to remember about the pathways, and as many of you are very experienced nurses and you would know a lot of these things, I think the one thing that it's really great for this website is to help train new nurses, because often the stuff is really a little overwhelming when you start. And so by going to this website, it actually gives you pretty concise, dedicated information on how to approach IBD, and it gives them a nice resource that they can use with lots of information. So our next steps for 2024 are to promote and disseminate national CCPs. And so we're actually going to be, these CCPs are actually going to be moving to the Crohn's and Colitis website. So as you know, in Alberta, not many people speak French, although we do, although my research coordinator that's helping me with this does speak French. And so in order for us to move them to the CCC website, they do need to be bilingual. So they're going to need to be translated into French. And so this is one of the challenges that we have. And then we continue to meet with our regular review with our group, our advisory council, as well as the members of our committee, to make sure that we're updating our CCPs every year. So after November is when we'll meet again in person, and then we'll be updating our CCPs. And as you know, there's more and more drugs being approved all the time. And so this is going to be a big challenge for us. So that's all I have. So, but I'm happy to take any questions if anyone has any. Would you say the decision tree for advanced therapies are influenced by what's covered? Yes, that's a really good question, Karen, because I think that's one of the challenges we wanted to say in terms of, we wanted to say what's available, but I think what's available in Canada. And so we know that there is going to be some challenges with some therapies in some provinces, but we wanted to make it as kind of generic as possible that it actually could apply within Canada. If therapies are not approved in Canada, we made a decision a while ago that until they're approved, that we wouldn't add them to our website.
Thank you for a fantastic presentation. I liked how you use the case studies to draw attention to all the different guidelines that are available. Just a question from Jennifer, is there any plans to make this mobile app friendly?
Oh, I think we haven't made, and I'm gonna have to talk to Crohn's and colitis. So ever since we've been collaborating with them and that we wanted to bring forward to make them nationalized, I think that's the next, they're going to be updating their website in general. And so then we can talk to them about, probably first it would go on the Crohn's and colitis website, but we can talk about them being on some sort of, I agree. Some of them are a little too detailed, I think, to be on an app, but I think there is some stuff or basic things that we could have definitely on to be mobile friendly.
And do you know multiple people across Canada are an Epic. I've stolen a number of UVA's templates for my letters. Do you know if we can share across provinces and locations?
Actually, that's a really good question. So like Karen Wong is our super user here. She's next door, but I don't actually know. I don't know how, I haven't actually stolen from anyone else. So it's easy to steal within our system, but I don't know about if we can share across.
No, it is. It's great typing in the IBD and then it just populates and then you just click to.
Yeah. And if you want, Cynthia Xiao's pregnancy stuff is the best too. Do you have a pathway for post-polypectomy surveillance? So I think that's included in our in the pathway for dysplasia, but I haven't looked at it recently. And so I could quickly pull it up. I love at least we have an easy website to remember, so it makes it really easy. So let's go to our dysplasia for providers, colon cancer. It does, I don't know if it has a specific one about post-polypectomy, but that is something we probably should look at. So that's a good suggestion. Because I don't think it actually specifically talks about polyps. It just talks mainly about how often and how to prescribe, but then it doesn't actually talk about polyps. But that's a good question that probably we should be adding in, as that's becoming a more common process. Is there a CCP to help you choose your advanced therapy? So I'm going to tell you, you do not know how controversial the choosing of advanced therapy, the therapy decision tree was. And so I think I assigned them to review. And I think between Remo Paniccioni and Frank Hunchin, I think they spent like an hour and a half on one section of the thing. So we've tried not to be too directive. We kind of wanted to give a little bit, because there's a balance of being directive and saying patients going, because these are actually on a website where people can see them. We wanted to make sure that we weren't so directive that patients would say, I think my doctor's doing the wrong thing, but also like to give a little bit of direction. And so I think it's probably almost erring a little bit too much on not enough direction. But I think that's that's one of the ones we're going to be reviewing on a regular basis. And so I bet you that will change over time, especially as we get more and more therapies. Do you link the information to a trial, to the monographs and whatever? So I don't think we've linked to the monographs. So that's the question from Barb, is that partly because I find the monographs are really challenging to read. We do have references at the end of every protocol. And so the hardest part is as more and more trials are getting updated. There is, I'm gonna like shamelessly, whatever, there's an app that was created by, I think it was Takeda, that actually has all the studies that are done. I don't know who, if anyone has that app, is it the CT Lexicon? Do you guys have that app? And so it's let's see, it's like this. And so this one actually links to all the studies. And so I feel like it's hard to keep all of that updated, but that's another good resource for you. And specifically for advanced therapies, I agree, like, because these are being, hopefully you have that resource for, I think you need a code for it, but they'll give you the code easily.
And if I remember correctly, the code's pretty simple. It's like IBD. So
Yeah, it's super easy. But it's like once you've entered it and you don't remember it anymore, then you don't have to put it in again, I think.
Yeah.
So, yeah. In the CCPs, is there for TDM? So there is actually, we do have a CCP on like optimizing therapy and trying to and so we actually have a depending on it's let me just see if I can share my screen. This is so much easier to show live. So basically this is you guys probably see this is the loss or partial response to therapy on advanced therapy. So it kind of talks about vedolizumab, when to assess and how you can dose optimize. And so I'm going to say the evidence to use levels was actually very controversial for our group as well. And so I think it doesn't, other than for anti-TNF therapy, I think that's the only one where we recommended that you use drug levels. And so this is the pathway. So active inflammation, patients on therapeutic drug monitoring, patients on other advanced therapies, they said refer to table 1. And then if there's subtherapeutic, you dose escalate. And then this was kind of like, this one's really a nice table because it actually shows you if for Entyvio or vedolizumab, you escalate to Q4-week dosing. For ustekinumab, you can escalate to Q4 or get an IV reload. For tofacitinib, you can go to BID. For upadacitinib, there's actually no dose optimization. Oh no, there is 30 milligrams BID. Risankizumab, there's none, and ozanimod, there's none. And then it talks about fecal cal and clinical approach, and then a little bit about TPMT levels. So this is actually a really nice CCP that we've developed here that will be helpful to you for that kind of process. Let me go back to those questions. And then I'm trying to remember if they actually have the guidance on it hasn't specifically done that, but you're right. That's a really good thing about the higher targeting with perianal disease. So that's probably should be included. So our new nurse practitioners graciously repeated the content ease of use. So that's good. Thank you for that, Barb. I appreciate that. I know some of my other colleagues that have new nurses training in their clinic. It's a really good place to send people. That's not tons of information, but it's not too overwhelming, but it's actually really quite. And then by working with people across the country, I think it's been really nice to hear different perspectives because sometimes you end up practicing just like the people you work with. But I think IBD practice across Canada is relatively similar in part because we're doing this. And I think especially as new therapies come out, it's been really great to work with people to make sure that we're updating them so that they're not, like you said, 2014 pathways when we're practicing in 2024.
Are there any more questions for Dr. Kroeker?
I hope this was useful to you guys.
It was fantastic. Thank you. I am trying to find the password for that lexicon site. I know I have it somewhere, so if anyone's interested, I can forward it out to you guys later. Oh, one more question from Miss Curry. Do you anticipate a dual biologic pathway?
I'm going to say probably not now. And so I think the one thing we wanted to be careful that it wasn't on the bleeding edge. We wanted to make sure that everything we recommend on the site is not necessarily off label and things like that. I think obviously when this UC and duet CD trials get published, I think then there's going to be more impetus for it depending on what those results are. And so I think we will always wanted to have the recommendations to be pretty solidly grounded in the literature. Maybe an unfair question. No, Barb, I love your questions. My new work Bible. Good. I'm so glad to hear that, Karen. You have to come back and visit us sometime. We had so much fun when you visited.
All right, looks like we are no more questions coming in. So thank you everyone for taking your time to attend tonight. I hope you found this information useful. And even if you're familiar with it, it's always nice to get that nice reminder of what's out there and that it's being updated constantly. And thank you very much for giving us your time. We know it's very valuable and how busy you're up at the U of A.
Yep. Thanks so much. Have a good night, everybody.
Have a good night, everyone.